Thank you, Ritu. Good morning, everyone. I wanted to go ahead and welcome our panelists. As Ritu mentioned, we have a really powerhouse of executives here. And I wanted to go ahead and get started with the introduction. So Mark, if you don't mind pulling up our slides so we can get started on the panelists. So starting off with, so Tom Luby, he is the Director of TMC Innovation. Tom was over J Labs at TMC prior to this and started his career at Johnson & Johnson Innovation back in Boston. Tom has a Bachelor of Science in Biology from State University of New York and a PhD in Immunology from Sackler School of Biomedical Sciences at Tufts University. So thank you so much, Tom. We're really excited to have Tom on board to be able to talk to us a little bit about what's happening in the medical device, the digital health, the private industry, and the innovation, influx of innovation that we've seen in healthcare, especially in Houston. Our next panelist today is Roberta Schwartz, I think. Yes. She is our Executive Vice President and Chief Innovation Officer here at Houston Methodist. Of course, Roberta wears multiple hats. In her responsibilities, she's responsible for overseeing the operations of the flagship hospital here in the Med Center, the 933-bed hospital. And she has also been serving as the Chief Innovation Officer and been working extensively in the past couple of years in the areas of digital innovation, including telemedicine, artificial intelligence, and big data. Roberta earned a Master's of Health Sciences from Johns Hopkins and also has a PhD from the University of Texas School of Public Health. So thank you again, Roberta, for being able to represent not just the healthcare industry, but also talk about some of the innovation that Houston Methodist has been pioneering and partnering with the different industry leaders. And our next panelist is Chris. I will not try to murder your last name. Chris O. So Chris O is the Chief Development Officer with HCA Healthcare. He oversees all of the developmental operations for the Gulf Coast Division, and he's responsible for the strategic growth, including physician partnerships, service line development, network integration, and all other efforts to improve healthcare programs in the community. Now, Chris graduated from Texas Christian University with a bachelor's degree in business administration and a master's degree in business administration and a health sector management certificate from Duke University. Chris is out here to share with us his perspective and what HCA and other organizations have been doing in terms of collaborating with the different rural as well as urban health systems and how they've been working with the different aspects and obviously some of the challenges that we'll talk about COVID as well that has presented health systems across the country. So thank you, Chris, for being here. And last but not least, our final panelist is Craig K. Craig K is AVP of Community and Population Health at UTMB Health. He also wears another hat of being the Executive Director for UTMB Healthcare Systems and serves as the Administrator for the UTMB Health multi-share plans, as well as the HCS Choice One, which is the Medicare Select program. He directs the daily operations for corporate office and provides executive leadership within the Department of Labor Operations. Craig holds both a master's and a bachelor's in arts and communication from the University of Houston. And we're excited to have Craig on board here today so he can talk a lot about kind of the population health aspects of healthcare. So without further ado, we're going to get started with our opening question for the panel, which is, what are some things keeping you up at night? What should be some healthcare priorities in Houston? And unlike the presidential debate, there is no mute button here, so I had to put that in. So I respect the speakers. I request the speakers to kind of limit your answers to about 2 or 3 minutes, so we have time for everyone to chime in, and then we have lots of other questions down in the panel. So, Tom, if you would like to get started.
Happy to, Mitali. I think I'm supposed to speak from the startup perspective. So if I think about, if you're a healthcare startup in Houston, things that keep you up at night, really 2 things, and they're interrelated. One is risk capital, so your ability to be able to fund the next milestone in your company. And associated with that is talent. I think Houston is blessed with a lot of young, early career technical talent, engineering scientists, medical professionals, but still is emerging as an area for more mid-level, senior level management talent that know how to do product development and move med device or digital enterprise ready opportunities forward. So, if you start a company here in Houston, you have to rely on the community around you very much. You're likely to be more scrappy than anything else when you think about how you're going to fund your next milestone, and you'll be looking to be in a community that can continue to attract talent to Houston, so you can take advantage of that as that develops. COVID's hit all of that pretty hard. I think especially on the med device side, most med device companies imagine that they'll partner with a strategic at some point, med device startups, in order to really commercialize their product. And most of the large strategics in med device have had a rough year, to say the least. And so that right now has created a bit of unease in the startup world as to when those strategics will get back to really thinking about partnerships and providing risk capital back to the companies as well. So it's a challenging year if you're a startup founder or startup leader, but this too shall pass. So that's probably what's keeping them up at night. Me personally, I'm just trying to figure out ways to get them all down the road a little bit.
How about you, Craig?
I really think about it in my role really from 2 different perspectives. I think the first is from the payer model, thinking about how we're moving really rapidly from a fee-for-service or cost-based world really to a quality, to alternative payment models like bundled payments and different directed payment models in Texas. We all know that in our state, the Texas 1115 waiver will be sunsetting soon, and that really represents billions of dollars for the state of Texas for healthcare transformation. And as we think about what that means when that goes away, what does that look like for the landscape of healthcare in Texas, especially for that Medicaid, low-income, and uninsured population? So really thinking about those negotiations with CMS in a state that has not, at this point, been willing to move in the direction of Medicaid expansion. And then really, I think some things really kind of happened for a reason. If this panel would have presented, 3 or 4 months ago, I wouldn't have had this other perspective. Since then, I've had the opportunity to recently take over management of UTMB's care management enterprise. And that has been very enlightening to me, coming from this world of the 1115 waiver and all the work we've been really doing, really in transition and really thinking about what that future holds and how we really coordinate care, to being really rolling up your sleeves and in that work day to day. And the other thing I think that keeps me up at night, and that I think we all probably share, is really thinking about our area's unfunded, underinsured population, and how do we coordinate their care from a care management or care transition going forward. I think that's something that, as a community, we really need to be thinking about. How do we work collaboratively amongst all of our systems, because many of these folks in that very vulnerable population touch all of us in some way.
Thank you, Craig. Now, have you actually seen an increase this year in the uninsured population, a significant increase, or how has COVID kind of impacted the uninsured population?
Actually, it's funny you ask. Recently, in a discussion with our care transitions management team, we were kind of looking at some of our higher dollar cases, those that have had a bit of a longer length of stay, things of that nature. And there is, I think there is a correlation. We have had an increase of individuals during these past several months, especially those that are uninsured or underinsured, that seem to be sicker, that seem to have more issues, that are really requiring a higher level of care and really a higher level or different degree of transitioning them into a safe transition of care. When they leave our hospital, what is that next step that, is most appropriate?
Yeah, that's right.
I do want to add and probably ask you, because it's very hard to tell in this year. When all's said and done, I feel like it's going to be 2021 before we figure out really what this data is going to show. Because to a certain extent, we've had a lot of COVID admissions, and they're being paid for by a different arm of the government. And then we have a lot of people who aren't coming to us for care at all. So all of us have showed this marked increase. Even those of us who have been a little bit lower on the uninsured side, right, have shown this marked increase, but it has a different funding source because it's COVID. And then I don't think I know how many people are not seeking care because they don't have insurance yet.
Absolutely.
I mean, it's spectacular. I mean, yeah, everybody's up in it, but I mean, will we know? I mean, even the insured population is difficult with care transitions right now. I mean, it's a terrible time to figure out all the homes that people belong in, and I don't know if you have thoughts on that.
We're actually in our ambulatory space through our population health umbrella, really starting this week, in fact, launching a What Are You Due For campaign, trying to get out to the population to say, if you haven't sought care during this period, it's time to really get back into, the healthcare mindset for preventive care, because you're exactly right. What things haven't been done? What are the things we're going to start seeing because, those are very real things we really haven't dealt with in the past.
What about you, Chris?
Yeah, I think the big thing for me that keeps me up at night, Ematali, is just access to care. Very similar to kind of what Craig was saying, but thinking through 7 million and growing in Houston, are we putting the right access points? Are we putting the right resources, the right physicians in the right places to ensure that all Houstonians and all the counties that we cover, which is inclusive of Galveston County, Corpus and South Texas have the appropriate settings of care. I think that the pandemic has opened my eyes of being a relatively new Houstonian. We moved down a year ago from Dallas, that the collaboration between the health systems is going to help us in the long term to make sure that everybody has access to care. And the pandemic has also helped with regards to expediting things like telemedicine and other technological savvy type areas to get those patients access to care. But I think two other kind of quick things that help me go back to sleep at night are, one, HCA now partnering with the University of Houston and the medical school, much like the other systems in town do, to do our part to help with the provider shortage. You know, even though we've got, 20,000 physicians in the medical center here, there's still a desperate need for physicians. So our part, working with the University of Houston, helps me. And then the other thing, it's just those level of specialists for HCA in particular. You know, across our division of hospitals, you know, we see almost 1 million patients in the ER every year, which is staggering. And it's ensuring that we've got the right specialists that can make sure that we take care of those patients or get them to the appropriate setting of care. And kind of to the point of where is it going, you know, what we've seen, you know, to people not showing up for care, to Roberta, to your point, you know, we are seeing our low acuity type businesses in the ER is going away. And we're not sure if that's coming back, but that might be appropriate. It might be going to a more appropriate setting. But we're seeing sicker people now in the hospital that are potentially delaying care. So access to the care at the appropriate time, I think, is going to be paramount, you know, for us moving forward.
And Roberta, you barely sleep, so lots on your mind.
I want you to know that the thing that's keeping me up the most is the fact that I am unable to help my son with his geometry and chemistry. I'm just a lousy tutor. But when we look at, I think I will put on two hats for a second. One is, you know, the hospital. I mean, the hospital business has changed, and we all are facing it, right? Who's coming back? What are they coming back for? Where is the surgery? Where are they going now? Where are the strokes? What happened to the heart attacks? I mean, you know, we're getting people back in the healthcare business the way we had it a year ago is just very different. And so I think we're challenged by figuring out where that has shifted, and when the sands come down, what is it going to look like and how is it going to feel? The second part is, when I look at the innovation hat, the rise of consumerism is very real. It's very different. And how people want to interact with healthcare systems now that they've tasted telemedicine and they like it, and they like making their appointments online, and they don't want to touch a device, and they want to do things very differently, means that our business has to quickly learn how to do curbside pickup like HEB. You know, and has to do things very differently than they were done in the past. And in a year where a lot of projects were put on hold due to COVID, right? Because, I mean, gosh, you had to turn a lot of resources towards that. How do you not only quickly catch up, but then leapfrog to get to where people want you to get to very quickly? And I think that is, it's required, but it's tough. And there's a heavy lift. There's a heavy lift on poor IT and everything that we're asking them to do. And we all wanted yesterday. And then you have a lot of new companies that have great ideas that want to get in here and help you transform. But there's only so much a health system can eat up, you know, and that's, so I think there's just a lot of big changes. Prioritizing those and dealing with things in stages is tough. Thank you.
So this next question is for you, Tom. And Houston has been obviously known for the Texas Medical Center, but it's also in the past several years, and thanks to a lot of work that TMC has been doing, is getting known to be an innovation startup. So what makes Houston a unique innovation destination for startups, in your opinion, besides the TMC?
Yeah, so, you know, I would say, so first, in terms of the question, there's really nothing unique about Houston, right? So it's like the idea that, you know, there's, you know, some special sauce that, like, you know, Houston has is is probably not really accurate, but there is a lot of enthusiasm around creating an opportunity for startups to be here in Houston. That's true in other geographies as well. You can go around the country, around the world, and you'll see people thinking about healthcare as the next vertical for them and focus on startups and talk about innovation. So I don't think that that's unique to Houston. The medical center is unique in terms of its quality and quantity of care, for sure. And then, I think it also is incredibly important that we have the educational piece that we have here as well. So training programs, very, very focused technically and medically as well. That's important. But I would say the reason Houston has a chance to be successful is that people are willing to work together towards it here. We talk about our community all the time as really, at the end of the day, the reason that a startup will make it or not, right? Because, you're going to need to get access. You're going to have to understand what the real clinical unmet needs are, or you're going to have to understand, really what the regulatory pathway or the commercialization or the reimbursement pathway is going to be. And you can't do that in a vacuum. You can't Google that stuff and really understand it. You have to be able to get in front of people, talk to them, multiple people, really start to understand. Keep asking why, and then at some point, you get a sense of well, this is a really good solution, or it's not. But either way, I think the opportunity for startups here in Houston is that access that people here are willing to create. I came out of the Boston market. You want to talk to clinicians in Boston, you take a ticket, you wait online, and you probably don't talk to the real experts there very easily. But that's not really true here. You can, and they'll be willing to sit and share with you. So, I think that community and that willingness to be supportive of startup here in Houston is incredibly important. Because it's not the funding right now, as I mentioned before. Startups, you have to be scrappy here. And there's still an emerging talent thing that we're working on. Those are the things that I mentioned keep startup founders up at night. So Houston's differentiation is in the community here, the willingness to be supportive, to work together, to really try and define, what solutions have merit against the different unmet needs that the medical center and the healthcare community here face.
So this question is for Chris. Do you see more consolidation in the market? What is the future of rural healthcare? And do you see cities like Houston or systems like HCA leveraging the hub-and-spoke model more than what they are doing right now?
Okay, yeah, that's a big question. So I'll address it kind of in bits here. So first, in terms of consolidation in the market, in terms of the big acute setting, I don't think so. We've got a numerous amount of acute type settings that are positive or solid in the market. So I don't see that. Where I see more consolidation is more in the access points like we talked about. You see all the different things HCA is involved in, as well as the other big systems. Consolidation of potentially freestanding ERs, consolidation of urgent care centers potentially, consolidation of ASCs where COVID has impacted them and maybe they haven't been able to weather the storm as well as some of the bigger systems like HCA and Methodist Memorial, UTMB that have really buckled down like we did 6 months ago. So in part, I do think there's some consolidation you'll see, and I think where you'll see HCA be opportunistic is in some of the ancillary type touch points. We're a company that's big with 190 hospitals that we spend roughly $4 billion a year in capital. So we've got the funds, but it's working with the opportunistic in the right way to get that setting of care, the appropriate setting of care to patients. So that's my thoughts on consolidation. As I think about rural healthcare, I think is very important for us in terms of partnership. We view rural health systems as partners for us, and really, our viewpoint is that we want to ensure that recovery is done in the communities that patients live, and so we've invested, a lot in our rural partnership. That element, we've got a team that's dedicated to outreach. We've got a vice president of rural outreach that works with those rural facilities, and then investments in things like we've got a consolidated transfer center when there are acute level things that the rural facilities just can't handle, but then also in terms of technological elements that can ensure those rural providers and facilities know when their patients are in our hospitals and we can get them back out to that community. And then I think lastly, just creative ways of partnership with the rural sector, thinking about MSOs and management service organizations that can help them sometimes get access to rates for different things that because of HCA's size and scope, they might not have access to. So working with them in creative ways to help them stay financially sound. So that's a little bit of my view on rural. I know right now they've been the beneficiary of the federal funding that's going on, but after the fracking bust, after Harvey, now next year, and Roberta, you kind of said it, there's a lot of unknown, there's a lot of fear when the money dries out. So we want to stay close with those facilities to offer help in any way we can. And then lastly, hub and spoke model, to touch on that, and I say this with a little bit of a grain of salt because we've got 3, specialty type hospitals that are in a triangle around the medical center between Texas Orthopedic Hospital, Women's Hospital of Texas, and now our HCA Medical Center. But I think really the view of HCA is to continue to push care out to the communities where the patients are. You can't do everything everywhere, but I think where there are community needs, and you think about trauma centers in particular, there's a shortage of that in the Houston community. How do we push that out to the communities to ensure access to care is efficient and quick for those patients? So that's my thoughts.
Okay. How about you, Craig? Do you have any thoughts on that specifically, since you do work with a lot of the uninsured?
As I think about the rural markets and I think about the work we've done in the waiver space, and I go back to that just because in Texas, the 1115 healthcare transformation waiver has really, I think, put the necessary dollars into many of the healthcare systems, especially in many of these rural markets where they've needed to make changes, whether it's been technology to invest some of those dollars into being part of an HIE or recruiting or trying to increase access to care in their particular systems. But as I think about these rural communities that we work in, you also have to think about the partnership for that next level of care. How do folks in a rural community access specialty care, and what does that look like, and how is that changing? One of the big tenets of this revised waiver 2.0, really has been a section that really looks at your payer mix, looking at in the various markets. Has your payer mix shifted from taking your Medicaid low-income population? So part of that is really looking at what is the access for those most vulnerable populations out there. And so I think that has been very good and very eye-opening that, people are really now focusing on that portion of that population and ensuring they have care. Because what we know is if we don't provide that level of care, that can really clog the system because, again, access to care for all populations is critical. If we don't, then, we're going to have that sicker part of the population that's going to, really just, kind of eat at a lot of the resources the longer they go without getting care. And so in our rural communities, you know, we've really tried to really push not only the education, you know, but really all of the work that, you know, has been done in the larger markets for them to be able to mimic out in those areas.
Okay, great. So Roberta, what have been some of the biggest barriers to innovation as a healthcare system? And do you see any new revenue models emerging to help support some of the innovation that's happening in the industry now?
So I think that, you know, and this goes back to a lot of the startups that want to come in, the biggest thing that's slowing health systems down at this point is just bandwidth. I think it really is nothing aside from that. There's now a will and a way it's a time where clinicians have never been as engaged and consumers have never been as engaged. And so I think it's a wonderful time. COVID, there was a great cartoon that someone showed me. It showed a picture of a CEO and a chief information officer, a CIO, and a picture of the COVID. And it said, which one is the most responsible for technology adoption? And it's, you know, all pointed to COVID. And I think that's entirely true, right? There's never been a time where consumers are more engaged. But when you come back and you say, oh my God, there are these 12,000 things we'd like to implement, it's hard. And you know that each one of them needs, you know, I always joke, oh, how many different integration connections can you create in 1 week? And, you know, oh, wait, that API you need, and what's that, you know, wait, what did I need to do? And, oh, did I need to talk to 16 people? And, you know, that's kind of the problems of getting them. The other problem is a lot of these companies, and Tom can probably comment, they're like a Venn diagram, and this one does A, B, and C, this one does B, C, and D, and this one does C, D, E, and, you know, separating them and getting everyone, I think there was a great comment from a technology person saying, please stay in your swim lane so I can tell exactly what you do, and I know, you know, because, you know, everyone, it's like, oh, I mean, everybody can do this plus a chat bot, this plus a, you know, web bot. I mean, it's kind of crazy. So I think that it's wonderful, but it makes it difficult to sort out how quickly you can get everything integrated into your healthcare system. Now, the question on new revenue models, there's big revenue models, which are risk, right? And how quickly are we all going to move towards risk? And I would tell you in the Houston market, not that soon that I can tell. I mean, it's just not, it's not moving at a speed of light. So I think that is a little bit big. And then there's littler, you know, there are bundled payments. There are Medicare shared savings programs. There are other types of things that require a level of, shall you say, case management, population management that is moving much more quickly. And I think that the innovations that you need to bring in to do some of those things and do them well and really track people and their habits are very important. And some of them are traditional healthcare roles. You know, oh, are you prepared for surgery or are you not? Some of them are even more interesting. I mean, one of the things that I remember, it stands out in my mind so clearly, which is how do you know if a senior is healthy? And the answer is you go figure out whether or not they've opened their refrigerator door in the morning. Because if they haven't opened their refrigerator door, they haven't gotten out of bed and opened. So what is the most important thing we can do? We can figure out if they open their refrigerator door. Wow. Right? So, and I was like, oh my God, that's so brilliant. But it's so simple, and it's not like I've never thought of that as my role. My role is to do their surgery and to do their everything as opposed to figure out if they open their refrigerator this morning. So, and if I want to know how they open their refrigerator, how do I get that information in a way that it can be easily digested, right, and it can get to the right parties who can then, you know, proactively reach out. So it's really, there's so many interesting things happening right now, and people have to come up with the ideas, bring them to, digest them, not be overwhelmed, and be able to get them implemented. And that whole trail is complicated.
Great point. So, Craig, what have you learned from the 1115 waiver initiatives that have been implemented so far? And what do you identify as the most challenging population health issues here in the greater Houston market?
You know, I think, to Roberta's point a bit ago, I think the waiver has really shown us how much data there is in healthcare. You know, I often say that, you know, a picture is worth 1,000 words, but this Texas waiver, you know, is really worth $6.2 billion, you know, and that we really have to show CMS, you know, what that return on investment has been. And so we collect a lot of data. We have to have that data to check the boxes, to, you know, to do our reporting. But I think we miss the bigger picture if we don't really take that data and we really don't dive into it and really understand it and really think about how do we use that data to really influence healthcare for the populations that we serve. And I think that many times the data has become so overwhelming, there's so much, and I think that sometimes we try to take too big bites of it. And so I think that what we have learned is to really try to focus on very specific pieces and really kind of dissect it and understand. And I think when we do that, and we're able to make some changes and celebrate some wins and really understand how we're able to really move that needle, you know, I think we're taking steps ahead. I also think that, you know, to that point of the question, the challenge, I really think the challenge in this really has been for the population really a lot of competing priorities, you know, in terms of it's easy in population health to say everyone should do this and this. We should all take care of ourselves. We should all, you know, have a schedule of this and this. But life goes on, and how do we fit preventive care, and how do we fit all of these things for all of the population into everything else? And I think that in this COVID world, one of the things that has really kind of manifested is, you know, the idea of telemedicine. I mean, UTMB has been a big proponent of telemedicine. We've used it through our relationship with the Texas Department of Criminal Justice through the prison systems for many years. We've used it in our regional maternal clinics for many years. But mainstream, I think telemedicine, you know, I think COVID has really advanced it. And I think there are going to be people out there that have got used to it and are going to probably expect that level of technology to a degree going forward, you know? So I think that it probably maybe helps open up a different level of access for the population.
And what would you think are the most challenging population health issues that we need to tackle in the healthcare community around Houston?
You know, I think the mental health is a huge one. I think that whole person care, you know, I think about states like California. I think about states like New York and some of the innovative work they're doing. And you really see them looking at what truly is no better way to say it than whole person care, taking care of the physical body and taking care of the mind, and really integrating that care, putting behavioral health services in very non-threatening environments, in the, you know, primary care environment, not, you know, having mental health centers, things of that nature. We've seen models of this in other states and other programs. I think we all know that we battle with the access to behavioral health as a country, and certainly in our market, even as rich of a medical community as we have, there's still probably not enough access. I think we know that. And again, that goes back to our partnerships with our behavioral health partners. And so I would say that, you know, I think behavioral health is probably one of the things that, you know, is a is probably one of the things that is the most difficult in a population health environment.
So when we first started planning this session, of course, this was pre-COVID, and when Ritu and I first met and we started talking about, Houston Healthcare 2025, neither of us had ever imagined that we would be sitting here in a room with wearing masks and not be able to shake hands or what have you and be talking about the C word. But given that we are where we are, what is your vision? And this question really is for each of you panelists, and from the different perspectives in the industry that you bring to the table, what is your vision for Houston Healthcare 2025? And of course, we have to say post-COVID, because that's certainly changed changed our worlds. I mean, not just delivery and access to healthcare, but even the long-term health issues that we don't even know what to anticipate in terms of post-COVID recovery and everything that comes along with immunization and all of the challenges. So given we are in 2020, what is your vision for Houston Healthcare 2025? And I'd love to get started with Chris, if you don't mind.
Yeah, sure. So I think back, and this is in January, our corporate headquarters is in Nashville. So it's in Nashville for a meeting with representatives with each division of HCA, so people from all over the country, and we did an exercise, similar to probably some exercises that each of the people on the call and each of the panelists do of, okay, what are our strengths, what are our potential threats for the next year, for the next 2 years, the next 3 years, and I marvel a little bit at, I feel like the Houston team was the closest, or the Gulf Coast team was the closest, because we said natural disaster is a potential threat, whereas not one of these executives from across the country said a pandemic. And so it's looking into the crystal ball when we think about 2025, because there's so much unknown right now. But I think some of the things that as a group we've talked about are going to continue to move the direction. Just thinking about the appropriate setting of care, like we talked about, we see all these ER patients. That has been significantly impacted, and that probably isn't coming back, but we've been seeing record number of patients in our urgent care setting. So the migration of patients to the appropriate setting of care, I think, will continue, and I think COVID, like it's helped all things technology, it'll also help patients get to the appropriate setting of care. So I see, more urgent care footprint in terms of a surgical footprint, more things continuing to migrate to the outpatient setting. That was already happening without COVID, but I think that will only expedite that movement, and I think HCA is poised to put resources and capital into ensuring that the appropriate setting of care is right. And then just lastly, obviously, telehealth is such a big thing, for everybody. We've all experienced it personally and professionally, and I see that continuing to be bigger and bigger and bigger, along with all the technological advances that I know Tom, the TMC, and you're doing and helping with, and the rest of us in the room and on the call are doing. So those are the big things that I think about.
How about your thoughts, Roberta?
I'm so excited that you think we'll be beyond COVID 2025. I'm ready for that now. So I think that consumers have made it pretty clear that we can't look the same way tomorrow that we did today. And I think that is without a doubt, we'll be much more technology-enabled as an industry, I think, within the next bunch of years. But also, I think I would agree that our roles are going to bleed into a little more of areas that we haven't necessarily been, in order to better organize care for people before they come, after they go home. We're already kind of bleeding into those spaces with bundles. I think you're going to see more and more of that as we are asked to kind of push into that population rather than just into the healthcare space. I think that's been evolving over the last bunch of years. I think it will continue to evolve. I think that you're seeing more importance on looking at areas like urgent care or LTAC, or kind of homes that, personal care homes that people are going to. There's much more of a reliance. I also have to say, one of the beauties of COVID is we're all working much more closely together than we ever did before. It has been a beauty of people trying to solve these problems, not by themselves, but together. And I think to Tom's point, those conversations, the willingness to kind of put ourselves out there and look at different ways of doing things, people welcome it. And so I think that's really, I very much look forward to the future. And we'll have to see, what happens if it's the same administration, it's a different administration, what's going to happen to the ACA. I mean, it's certainly going to be a very interesting few years.
What about you, Tom?
Yeah, so we think about it so 2025 doesn't seem that far away anymore. 2021 right on us. And, the trends that we see are, or what I think personally is we're going to continue to go away from sort of traditionally defined as the craft of medicine as we know it today. Physician-centric, pattern recognition, and more towards consumer-driven healthcare, which is going to be based on data sets and evidence-driven protocols as we move forward, which will allow for other places, consumer-driven places, to provide healthcare, which will be the same quality and arguably better quality in some cases than we have right now. I find it fascinating that, Walmart now is going to provide medical advantage plans, right? So think about that. Like, you're going to go into Walmart and they have a place where you can get you can sign up for your medical advantage plan and get your insurance and get your health care. And does it have, I'm not saying it's going to be kiosk-driven healthcare, but there's a part of me that says, you don't need a physician for a lot of the things that we've just been talking about here. Routine primary care, definitely access to mental health services. We see more and more data sets driving better and better evidence-based decision-making. Lots of clinical decision tools that are coming online. They just get better and better all the time. So I'm going to guess that we'll access our healthcare and quality healthcare in a much different way. And, if we continue to see the rise of, the inflection point happened a couple of years ago where, more people are on federal and state funded insurance than they are on employer-based. Employer-based insurance is going to go away. And that's going to drive a lot of people to look for their healthcare in a different way and in a different place as we move forward. Always still an incredible need for highly specialized acute care, but I think it gets consumer-driven, decentralized when we think about kind of primary care, mental health care, driven by data insights and technology.
Really, that rise up of artificial intelligence is really coming over the next bunch of years.
It's just, it gets better and better. I mean, it's such a buzzword. I hate to use it, but
sure.
Generally, the data sets, especially if we can get into, interoperability and you can keep your data and take it with you and, is that all happen by 2025? I don't know, but, it's certainly more interesting to think about using machine learning algorithms to understand data sets than, pattern recognition by a human longer term. I think that'll drive better clinical decision making. Just a thought.
Great thought. How about you, Craig? Besides more funding.
No, right. I think to the point that they've made, I think it's really, if we think about 2025, we could be sitting here and we'd probably be recounting some of the same challenges that we're talking about today. I think that's, if we're going to be very, very realistic and transparent, there are some things that we're going to probably always be battling in healthcare. I think, though, to the point that some of the other panelists made about the workforce, really encouraging, and I'm hoping that as each year passes, as each day passes, we all encourage our staff to work at the top of their license. I think that becomes critical with the number of folks needing healthcare services and the workforce of what it is. how do we think about healthcare delivery? Does it always have to be a physician? Can we have nurses do more? Can we have physician assistants? What other types of providers can deliver good quality care? And then I also think about, as we think about 2025, we must become more effective and more efficient in the way we not only deliver care, but the way we manage and take care of our businesses. Mm-hmm. And really think about, from the financial aspect of it, I often always say, no margin, no mission. That's been a saying in the healthcare industry for many, many years, and it's very true. And so really thinking about how do we as health systems become more efficient to deliver that highest quality of care, because we know that there are going to be many more demands on us. And not to go back to the financial part, but, I think we're going to be expected to do more, possibly for less. And we have to really, I think, be able to fine tune and hone in on, where are those efficiencies that we, can start mastering and kind of perfect as we go along.
Great thoughts. Now, this has been a great discussion, and obviously some very, very good perspectives coming from different niches within the industry. And we see a very, very busy chat window that Mark has graciously been navigating through. So I wanted to kind of move on to the next section of this panel discussion and open it out for some questions that, Mark, if you would want to, pick some of the questions and pose to our panelists, we'd be happy to get them answered.
Sure, we've largely had a discussion here. We do have a question for the panel. What are 3 takeaways that you advise organizations should work collaboratively if we really want to change our healthcare approach, addressing our challenges and moving the needle?
Great question. 3 takeaways. Who would like to go first?
Well, I think if we could all wave a magic wand, we would all love, I'm sure I can speak on behalf of everybody, to know the patients that move from my system to your system all around, so that we could actually meet the needs better of some of these people who jump from organization to organization. I think that's one where it's like a no-brainer. We wouldn't mind working together to get those people to the proper, appropriate healthcare home, because they spend a lot of time in it. It's hard to track them. One that would be lovely. The second one is some of these innovations take all of us and all of our brains and all of our data and all of our information. The third one is just continued learning. Those are my 3. We learn from each other and we compete, and some of that competition makes all of us better.
Any other thoughts?
One thing, and this is more just I think a relative point of where we are in this market, and me having come, not being a native Houstonian, but and I was telling Craig, I'm from Dallas, get it out there. I'm the jerk, the sad Cowboys fan. But as I've gotten down here, I've been I'm not going to say shocked, but I've been so pleasantly surprised by the level of collaboration between all of the systems. Because even though, I'm a Dallas guy and I love Dallas, I don't think there was that level of collaboration in Dallas. So I feel like Houston is in such a better place from a collaboration standpoint moving forward than other markets, and that's N equals 2. So that's small, but Houston is in a good place from a collaborative standpoint. So.
The only other thing I would add, I think, to Roberta's point is, about our shared patients and the patients that move from system to system. And, I think we've talked about large systems within the Texas Medical Center, members of the TMC. But we also have to think about our community partners, those partners like our federally qualified health centers and our faith-based nonprofit organizations in the communities. we often don't really realize the impact and the role they play. And I think that is something that is going to become even more important and more critical going forward, I think, with the degree of services that are needed, and really, especially in light of, maybe the lack of care that some people have sought during this past year, if you will, in that, more vulnerable population. What is the true role, and how do we really help, as larger systems, our community providers really excel? So that's just a takeaway from myself.
Mark, next question.
Sure. Do you think work from home is here to stay for non-clinical employees? Is that the new work model in the industry and here to stay?
Can I do it, Roberta, please?
I think for some people, yes. I think there's going to be a lot of people that want to come back and we need to come back. So I think it's going to be a mixed bag.
I agree. I think, so I would say generally from my perspective, work from home translates to increased flexibility. Like there are times where you could work from home now, it's clear, and be incredibly effective. But, can you be as effective working from home every day? I don't know. I find that it's cliche to say the water cooler conversations, but those things matter. And it's really hard to do, intentionally. Let's set up a Zoom and just, catch up. That doesn't really, at least that's not my experience. My experience is you have 15 Zoom meetings back to back, and it's all structured conversations that you're about to have. But I do think the one thing that we'll see, because this real bottom line effect, is a lot less business travel. I think more of us will be local, whether or not you're at home or in your workplace, than we have been in the past. I think that will, there's just too much opportunity to really impact the bottom line, especially in larger organizations. And, the technology has come along to the point where it feels like you can be as productive, not all the time, but more often than we would have thought in the past.
I don't know if any of y'all have experienced this, but at least in one of my areas, I've lost a couple of folks who have had opportunities to leave and work remote. One example just recent was a nurse in our care management, our utilization review area, that, had a great opportunity to work remote for an insurance company halfway across the United States, virtually, and had that opportunity. And so while we at UTMB have embraced telecommuting and the virtual workplace in many areas, there are still areas that, it doesn't fit. And so I think what we have to do is really look at the appropriateness of it. But I do caution that I think we need to be cognizant of the fact that, there's going to be more opportunities for people to have more opportunities themselves, really.
Up till a few years ago, it was definitely a very remote concept to work remotely in healthcare, and we're definitely not going to be at a point where we can all be in Cabo on a beach, sipping a margarita or, working remotely, but definitely the options are more now. Yeah. And as healthcare leaders, we're a lot more open to even considering that in order to be able to retain our staff and make sure that people that we don't want to lose because of health considerations or what have you, where they need to work remotely, we're a lot more open to that, I guess. Mark,
sure.
Next
we
question.
got a couple more. Evolving care approaches during COVID has revealed that change can occur fast. How will this remain post-COVID? So really, will our rate of change and innovation continue after COVID the way it has during?
I think so. I think it was already happening before COVID. I mean, COVID definitely sped it up, but I think it was already on the road.
I agree.
Okay. COVID-19 has exposed great racial and health issues. How do panelists see lower income patients and those of color accessing these new modalities of care, of developing these innovative therapies and systems of care, because it's not evident that these populations are being taken into consideration as part of the solution or leading innovation?
I can tell you from the statistics that we're seeing on adoption of technology, there doesn't seem to be a racial and, interesting, much of an age disparity on adoption of technology. So when we look at it, we're looking at whether or not we have various groups adopting it. Now, I will tell you, not all of these systems, and you don't go onto a telemedicine system and the first question it asks you, would you like to speak Chinese, Spanish, or English, right? I mean, that's not one of those things, but there is sometimes a button that says, I would like a Spanish-speaking physician. So I think that may become more prevalent to have things in a variety of languages, which would definitely help people to adopt the technology. Technology in and of itself in telemedicine is much more accessible to a wider spread of the population. And if you look at the populations that we're all talking about in terms of uninsured or lower income, most of them do have cell phones, which gives them a much greater access to both healthcare in a telemedicine fashion than they've ever had it before. So I think that's something there are some positives there in some of these advances, and I hope we will keep expanding it to give more and more people access.
Yeah, I think that, we talked a little bit about consumerization of healthcare and so different points to access healthcare, which certainly can be helpful for different demographics to be able to more easily access high quality healthcare. One of the things that we're tracking closely also is employer-based or on-site direct primary care, especially in light manufacturing and other areas as well, where they think about the employee not just so much about their productivity, but their overall health status. And for self-insured employers, they can be the outliers that drive a lot of the costs in their health insurance. So being able to take care of them more directly, more thoughtfully, right at the workplace is an interesting way for those employers to save money, which drives motivation and incentives there as well. So, seeing employers take more accountability to the overall health status, especially people with chronic conditions, is an emerging trend. We're curious to see if that starts to catch up a little bit more in the self-insured employer market.
I think going back to the earlier comment and discussion about taking health care to the people, into the community, working with the FQHCs, partnering with the faith-based organizations. Does an organization have a mobile, outreach that they can work with the local faith-based community? We're thinking in population health around how do we do, for example, hemoglobin A1C checks in the community. We have in population health a mobile unit that we're going to start going out and doing simple things like foot exams, diabetic foot exams, or doing, certain types of vaccinations and really taking it to communities and not stereotyping or saying this population or that, but statistics do show us that, there are certain areas that could benefit from, having additional services rendered. And so I think we have to, again, that data I talked about earlier is really using that data to really help us drive where maybe some of that health care can be directed, especially under, the pretense of this population health movement, if you will.
Now, we used to hear a lot about social determinants of health and how that has obviously a great impact. How do you all feel in terms of the current collaboration and the message that we've been discussing today in terms of using that, from both health system perspectives, from population health perspective, and even technology and innovation? What are some things that we as a healthcare community could do in terms of addressing those social determinants of health that are very applicable, especially in some of the more challenging populations?
When you look at it, and you look at the experiments happening around the country, and they're fascinating. The question is health insurers getting into paying rent, green spaces, food insecurity. I think that there's a lot of questions about how do we best solve these problems. In countries where they put a lot more money into those social services, they have lower healthcare bills. Or are they directly or indirectly related? It's interesting to watch Medicaid start considering some of those things. I will tell you, Medicare, I do not see them going in that direction. I don't see commercial insurers going in that direction anytime soon. I mean, Kaiser's probably one of the few to kind of keep your eye on, because I think they're probably doing the most fascinating work in this area. But I'm not really seeing enough of that discussion on whether or not increased levels of social services, I wish I was, but I'm not, would change the healthcare bill.
And a lot of that, I think, is happening, and where we do see the drive or the change or the action is many times on the back end for patients, when it's something that we need to do to get them to a
we need to get them out of the hospital.
Right. Next level or safe level of care, on discharge, How do we send Mr. Jones home, who he may have a roof over his head, but he couldn't pay the electricity, and he needs, oxygen or needs X, Y, or Z, or you send someone home and it's great to ensure that they have that medication, but what if they don't have food in the refrigerator? And so they don't take the medication because without having food makes them sick. There's so many things that we think about, or I should say that maybe we don't think about, that really fall in that social determinant arena. But truly, things I think we have to and probably should be even more.
HCA's got, a ton of markets, 190. What are you seeing nationwide in terms of which ones are furthest along and what's happening? What are you all doing?
I think, and I think about it maybe at a little bit more granular level of how we approach, because that continuum of care is really, really important. I think HCA is looking at, for the long term, how do we get involved with like we talked about, is there home health things? Is there a way to tie in the community after the post-acute? Because historically we've been in the acute setting, and that's really it. So, and this is not to think 30 years ago, way long ago with HCA, but how do we get back into that? And I know we've got pilots throughout the country. We're exploring that whole continuum of care. And I think one of the other things, and this is, social determinants, but also I think through the opioid epidemic and the challenges that creates from a social standpoint, initiatives that HCA is taking, where we have, thousands of people come in and there's tens of thousands, if not millions, of pills destroyed. So things like that, where It's still taking place at our acute setting at the hospitals, but those are some things that we're pushing forward with to try and make a nudge or a little bit of a dent in some of these social challenges. But I think the continuum of care is a big one that we're continuing to look at and analyze and pilot, and that's the way we kind of do it. We pilot in this market. If it works, then it disseminates out everywhere. But that's probably the biggest couple things I can think of.
I do want to give a shout out. I think a lot of the children's hospitals do this very well, and I do think that they are a fascinating group to watch as they kind of go down, and particularly as Medicaid becomes a little more capitated. And I remember reading the study from Boston where they found that they could keep asthma kids out of the hospital if they bought the family's vacuum cleaner. And really, I do find children's hospitals to be doing yeoman efforts in kind of some of this type of work, whether it's immunizations and other areas. I think they've been leaders.
Mark, do we have any other questions? Maybe we have time for questions?
Yes.
Okay.
Do you think that innovations such as virtual ICUs can help provide access to care to rural and outlying communities? And are there plans to expand these type of programs into other service lines?
Can you repeat that one more time?
Sure. Do you think that innovations such as virtual ICUs can help provide access to care to rural and outlying communities? And are there plans to expand these type of programs into other service lines?
Okay, so I can speak about ours. So we launched our virtual ICU. It was fortuitous timing. Can't make this up. We finished wiring all of our ICU rooms at the main hospital at the end of February. I cannot make that up. And I did not pick that date, it just happened to be. We've now finished the rest of our hospitals and are working out all the kinks of going live in our virtual ICU setting with the hope that we will be able to support other organizations as well down there. What you have seen is an explosion, I would tell you, of telepsych. Telepsych is everywhere because none of us have a million psych providers that want to come to the hospital situation. I do expect, I'm waiting, we just started tele-infectious disease at the hospital to support our infectious disease doctors. I anticipate within the next couple of years, I'm expecting teledermatology. I think that's coming because it's harder and harder to get those coming to the hospital. And we have telerounding in a lot of our facilities. I think that if you look at our model, that's going to happen everywhere, and it is going to be incumbent upon the hubs like Houston to help out partners around the rural areas, because that will provide better support in the communities and allow people to stay there. UTMB has been supporting the prison system using telemedicine for a long time. So I think that there are, if we look at places like Pittsburgh, places like Kaiser, places like Mercy, there's a lot more that will come in the coming years. But we anticipate, we are building our system with the anticipation of supporting other players. We're not ready yet, so please don't call. But I think that our anticipation is that's the right answer, is for places like Houston to be hubs of being able to support large swaths of the Southeast markets. And that's a place where you're going to see competition and collaboration become very blended, because places that are smaller hospitals, which you would have normally have thought of as competition, may want the support for some of those services that, you know, if it can make it cheaper for them, they're happy to get supported for a service that they need. I mean, telestroke, we're out at 7 hospitals. I mean, that's a norm now.
telestroke is a big one within ACA as a whole, tele-MFM, tele-NICU are the avenues that we're pursuing on top of, some of the things where it's challenging to get providers that don't want to come to the hospital at all. That's a huge opportunity for all of us too.
Any other questions, Mark?
I think that will cap this off. Thank you guys so much.
All right. Thank you. Thank you all so much for being a part of the panel discussion this morning, and you've given us a lot to think about in terms of not just Houston Healthcare 2025, but beyond. And we hope to continue this dialogue and this discussion in the coming years. So thank you all for participating. Thank you, Mark and Noel, for allowing us to make this happen.
Thank you, Mitali. I just want to cover the business side now of the chapter. I noticed we got some folks that are starting to drop off, so if you'd stay on, please. We've got some information to cover with you all. Again, I'd like to thank the panel for the great job you all did this morning. We covered a lot of information, a lot of thought-provoking discussion, and we had some great questions. I also, again, want to thank Mitali for the great job she's done, as well as our education group in putting this together. So just to cover a few things, I want to talk real quickly about the board. So I do want to introduce the board real quickly. Of course, our regent, who is Gina Bamberg, who's with HCA Houston Healthcare. We know that this has been a challenging year as a regent, given everything's been done pretty much virtually. Also want to, our past president, Jack Buckley, who's out of Texas A&M. Our vice president, Sandy Murdoch, who's with Texas Women's University, and Sandy's new to her role, as we announced that a few months ago when Rochelle left. Our treasurer, who's Cliff Bottoms, and our secretary, who's Lee Revere, and with the UT School of Public Health. And thank you, Lee, for all the work you're doing in setting up these WebExes for us. Our board members are Carla Braxton, Dr. Carla Braxton with Houston Methodist West, Lindsay Harper Crane, who's with the Michael E. DeBakey VA Medical Center, Greg Harrelson, who's with Memorial Hermann Texas Medical Center, Bill Hislop, Raymond Corey, who's with the University of Houston Clear Lake, Dan Newman, who's with Houston Methodist Clear Lake, Chris O'Keefe, who's with Harris Health System, Monica Rasmus, who's with Texas Southern University, Yvette Shaw with Texas Children's Hospital, David Wagner with HCA Houston Healthcare in Pearland, and Elizabeth Youngblood, who's with CHI St. Luke's. And Liz is new to our board, as you probably saw the announcement. And also I want to recognize our fellow board observer, Sean Curie, who's with the University of Texas MD Anderson Cancer Center. As you know, there's a message that went out about our board. All our officers and our directors on the board have been extended 1 year in their terms due to COVID, so we had to make that change. Again, that information was in an email that went out. There was also more information that Mark sent out to the chapter on an email on October 19th, so please take some time to read that. And then we do have the election and so forth coming up from the chapter in December. I do want to recognize our visitors. If this is the first time you're with us, we want to welcome you and hope that you'll join us for some of our future amazing events. I also want to recognize our new members. For those of you who become new members of ACHE since the last quarterly session in January, we'd like to thank you for joining our organization. Again, you're part of an organization that has over 50,000 healthcare leaders and members from across the United States, Canada, and also internationally. You're part of a very prestigious group of healthcare executives. So thank you all for becoming a part. And this is where I'd like to interject a thought on everybody's mind and ask yourself, who have you talked to over the last couple of weeks, or even who do you plan to talk to over the next couple of weeks about joining ACHE? You know, there's a lot of healthcare executives out there that this would really benefit them. So take some time to talk to somebody about our organization. Our 2020 academic scholarships, I'd like to announce those. So each year we give out chapter awards, and this year we were fortunate enough to have 5 named scholarships for those who are healthcare administration students. So our 2020 winners are Diane Arriaga. She's the winner of the Jephthah W. Dalston PhD FACHE scholarship. Megna Kapadia, who's the winner of the Dan S. Wilford L. FACHE scholarship. Jennifer Ho is the winner of the Charles D. Chuck Stokes FACHE scholarship. Angela Hsu is the winner of the Dr. David J. Fine FACHE scholarship. And this last name, hopefully I get it right, Madison Verzavelt, who's the winner of the Donald B. Wagner LFACHE scholarship. So again, congratulations to our 5 scholarship winners. I do want to recognize our chapter strategic partners. This is important because we couldn't do a lot of our events or even without these organizations. And so we'd like to thank the following chapter member corporate healthcare system partners, which include CHI St. Luke's Health, HCA Houston Healthcare, Houston Methodist, MD Anderson Cancer Center, Memorial Hermann Health System, and Texas Children's Hospital. A special thanks to the following strategic partners for their contributions at various levels. And again, they do a lot for our chapter and which enables us to provide these outstanding programs for our membership and also scholarships to our healthcare administration graduates. And these partners include Metastar. Metastar is a Diamond Plus partner at $25,000. Intercontinental Houston Medical Center, which is a Diamond Plus in-kind contributor. Our platinum sponsors are Page, Kindred Healthcare, Pearl Meyer, Clear Balance, Banyan Medical Systems, Kirksey Architecture, J. Tyler Services, Texas A&M School of Public Health, TPS Thayer, and TPS Thayer is an in-kind partner. Lindbeck Construction, who's a Silver Plus at $2,500. Center for Executive Education, UH Clear Lake, is a Silver sponsor at $1,500, and our UT Health School of Public Health, which is also at the Silver level. Please join us in thanking our strategic partners for their great support to our chapters. Give them a round of applause. Many of our programs would not be possible without their support. And year to date, we've provided over 1,800 education hours and 2,700 networking hours. Again, this is huge for our chapter, given that we're in a virtual world right now, so we continue to support our members in various ways. These numbers are really astounding given the challenges, as I mentioned, in 2020. And again, thank you to our sponsors for supporting this amazing work. I'd like to get into some other recognition. Our chapter committee and volunteer opportunities are going strong. We've now formed 9 committees and currently have over 115 members that are involved in these committees. And I get daily requests from different members reaching out to me about opportunities in which they'd like to serve. And I'd really like to thank Mark for all his work, as well as our chapter lead volunteers, who are Tyara Barge and Grace Ituwe. These 2 individuals have done a great job helping Mark out, and we want to thank them for all they do. Go to kind of some recognition on our chapters, our committees. I want to start off with our chapter award, which is chaired by Laura Kummer. The chapter awards committee completed scoring of our student academic scholarships and has laid out a 3-year plan, including our first chapter award event, which we've done in conjunction with our December 10th fourth quarter breakfast meeting. So again, we're really excited about acknowledging some folks. Our community service, which is chaired by Doug Blackard. The chapter has already completed over 330 hours of community service, and all that has been done during COVID. So thanks again, Doug, for your great work there. Our diversity and inclusion, chaired by Marlene Angelos. The D&I committee will be holding a face-to-face credit panel on the afternoon of December 3rd, so we're really excited about that. Education and events, chaired by Anne Claire France and Natalie Paul. Again, this is the folks that put on like this morning's event. The Education and Events Committee has put on a joint event with MGMA last week and is putting together both the What's Up Boss event on November 11th and 12th, as well as the mini conference on December 2nd and 3rd. So thank you all for your great work there. Looking forward to the What's Up Boss event in November. Marketing and Communication is co-chaired by Laura Gomez and Raj Desai. The Marcom Committee has launched our new website, which is under phase 1. They've revamped the newsletter and the chapter communications and is creating processes for streamlining event marketing. So Great job by Laura and Raj. Really, you can see the difference already. Our member advancement is co-chaired by Kevin Long and Patrick Browning. We've launched recently a 20-hour fall Board of Governors review class, and we've got over 79 participants already from 7 states and 2 continents. So you can see they're a big plus, and I know there's a lot of folks really excited about that. Our membership and retention is chaired by Grant Magnus. The Membership and Retention Committee is launching welcome breakfast for new members and looking at both expansion and retainment initiatives. Our mentorship is chaired by Annette Freebot. The mentorship committee has launched the first group of mentee pairings, revamped the program, and is preparing to launch a call for mentors and mentees later this quarter. So be on the lookout for that if you'd like to serve as a mentor or if you are one desiring to be mentored as a mentee. Our student member and involvement is co-chaired by Faiza Hatib and Gerald Goodman. The Student Membership and Involvement Committee is working on the creation of student-specific content events and is increasing partnerships with both undergraduate and graduate healthcare administration programs. So again, we're really excited about that committee as they do strong work. Please contact our chapter administrator, Mark Viscone, for more information about joining one of these committees and getting involved. Again, this is truly one of the things that we focused on last year when we got our membership survey back. We had a lot of members that were looking at opportunities to get involved, and again, you can see by the number that when you look at our total membership, you know, being at almost 1,500, and then the number of people involved in committees at almost 120. That's a good improvement for our chapter. So hopefully that is what our members are looking for. News from the national level. So we had our chapter leaders conference last week. A lot of great information put out. I know they're still evolving, and you know, this is the first time they've done that virtually, so that was an adjustment for all of us. And still got a couple of more sessions that I've got to catch up on because it was a pretty busy week last week, and so they were able to film those, so some of us could catch up on them later if we missed one. But just to for those that are recertifying as a fellow, that we're supposed to recertify by the end of this year, you know, that has been extended to March 30th of 2021. ACHE full membership length requirement to become a fellow. This is huge. They've reduced that time period from 3 years to 1 year. So again, you used to have to wait 3 years before you could advance. No longer will you have to do that. Now it's just a 1 year requirement. But all the other requirements are the same. So again, you still have to pass the Board of Governors exam, you still have the community service and other things. So again, that time period has been reduced. And National has redone their membership program to add structure and break into 6-month cohorts. So if you have any information on that, please go to the ACHE website. So in closing, we are planning on holding a mini virtual conference on December 2nd and 3rd with a myriad of speaker panels. You'll hear from experts, and you'll also earn up to 9 hours of face-to-face. This is big for us because, again, we couldn't hold our conference that we usually do in October where you're able to get 12 credit hours, but this will enable you to get 9. We have 2 more ACHE national speakers. The first 2 were excellent, so I'd encourage you to take part of those. Each gives you 1.5 hours of face-to-face. There's one tonight as well, so take advantage of that. And again, the first one will be Thursday, November 5th at 7:30 a.m. And the last one will be on Thursday, December 3rd at 7:30. Again, remember that space is limited, so if you sign up early, you'll get a slot. If you wait, there's always the risk of you not being able to get, because they limit those. So our next quarterly breakfast meeting will be on Thursday, December 10th. Finally, we'll have 2 virtual community service events on Saturday, November 7th, the Walk to End Apraxia and the MD Anderson Boot Walk to End Cancer. I encourage you to join one or both of these virtual walks. You do get credit for community service, so again, take part of those. More information and registration is available on the chapter website, so just go to the site and you'll be able to get the information you need. I hope you've enjoyed the panel discussion, and hopefully we'll see you at one of our upcoming events soon. As a reminder, be safe and stay healthy, and reach out to Mark or I if you need any kind of information or you need assistance. Thank you again for joining us this morning, and be safe.
Thank you all, and we'll hope to see you at a future event soon.
Have a great day. Thank you.
Thanks, Mark, Lee, Natalie, take care.